of the mistrust engendered by the Tuskegee study of untreated syphilis, to the impacts of antibiotics like penicillin when introduced into post-war Italy, to the positive impact of physician-patient racial concordance and the uptake of preventive measures among Black Prize for her senior thesis entitled A Dilemma of Diversity, the relationship between ethnic fractionalization and universal health coverage in Africa. She had previously worked as a research assistant in health economics at the Tobin Center for Economic Policy at Yale before coming back to Harvard. And Dr. Alsan and Yusra will speak with us today on interest groups, ideology, and indirect lobbying, the rise of private health insurance in the United States.
Thank you. Generous introduction. And Yusra also noted before people entered the room that she took a transformative class with Dr. Farmer early in her undergraduate career that really changed the trajectory. So we're all 6 degrees or less away in some sense. But this is still work in progress, so we're really excited about your comments. I'll be doing most of the talking. Yusra will be taking notes, but we'll both chime in. And then I thought we would talk for 45 or 50 minutes with the presentation. And then again, please feel free to interrupt. We're used to economists who basically interrupt. By now, we would have been challenged on something I said. So feel free, especially if there's anything unclear, or certainly there is a lot of expertise in this room that we would like to cultivate. And if people can hear me on Zoom, and I'll just keep going. So our motivation for this project was basically that the United States is exceptional on many margins. One of them is on health. So we spend more on health care than any other country. 1 out of every $5 of GDP, or roughly $13,000 per capita. And there was a bit of a debate. One of my favorite economists, Uwe Reinhardt, health economists, would say, it's the prices, but expenditures are P's times Q's, prices times quantities. And it would come out and say, it's the prices. That's why the US spends more. But a lot of practical work since has shown that Uwe was actually right. It is the prices, quantities, meaning, in other words, that we're spending more, very same bundle of goods. Now, obviously, the other Q that's in the background is quality. So maybe the quality we're getting is much, much higher. In fact, again, if you look across other developed nations, on average, our outcomes on things that healthcare can or maybe should affect are actually sometimes strikingly poor on average. And then if you're interested in health equity, like I know many in this room are, just a lot of heterogeneity, which is very concerning. So we could go through a bunch of different examples. This is just one, maternal death rates. This is from the Commonwealth Fund. You can see the United States here, which is again, on average higher than other countries. But the trends on the left-hand side are just showing this is cross-country, that's cross-group. And for non-Hispanic Black Americans, very high rates of maternal mortality. And actually that trend is kind of going in the wrong direction. It's actually increasing over time. You could look at it with high excess deaths from the pandemic. This could be delays in people seeking care, or maybe a poor management of comorbidities. But this is all actually antedating the COVID vaccine. But I think, again, many in this room are very familiar with these inequities and are dedicated their life to kind of righting them. But the other thing the United States is exceptional is how we actually finance and provide So again, from the late Louis Reinhardt, this is just looking at our flow of funds. So that was his chart in 2011. It's just gotten more complicated by 2019. You know, we've got PBMs, that wasn't a thing when I was in medical school. We've got health policy wonks, maybe, I don't know. Marketing consultants, Ox is getting larger and larger. There's obviously many different ways to classify health systems, but one way is just to take sort of a network analysis and look at basically where are you in the network. Here are all other developed countries, and here's the United States on sort of its own network with Switzerland. And, you know, why is that? Obviously, we have a very complex system, and many have a model, if you think about, you know, the VA or traditional Medicare, but the majority of our healthcare is actually privately financed and publicly financed and private subsidization and privately provided. So that comes in different flavors or different names. You might hear of employer-sponsored health insurance or commercial health insurance, but it's essentially private health insurance. And I'll just, you know, we won't spend a lot of time on this, but I think despite reforms, including the ACA, many are uninsured, underinsured. And going back to Scott's description of sort of the work in Oakland on doctor diversity, what was striking about that, and you know, another place I've been working really recently is Flint, Michigan, is how many people are unsure. They really don't know what they have or what's covered, and they're afraid. They're afraid of getting hit with a major medical expense. And so this has actually piqued the interest of a lot of economists, maybe a little bit late in the game, since we're used to looking at marginal changes and thinking about bargaining tools and whatnot. But I think our rising deficits have led to us being a little bit more concerned about that. And one thing to note is when we think about the United States and the history of it, you know, this is from the IOM in 1993. It says that, you know, we're kind of alone among developed countries and lacking some government and comprehensive health coverage for all of its population. And our divergent path became apparent primarily after World War II. And so that's really going to be the focus of our study here, is the post-World War II era. And there's lots of different narratives really about how we got this very unique bespoke system. Case and Deaton, famous Princeton economists, talk about it as a historical accident. Blue Cross Blue Shield, if you're reading their fact sheet, talk about the strength of American industry and unions assuming stronger positions and employer tax exemptions. In fact, that, I don't know if you know I was taught that's the narrative I was told. It's all about the strength of the unions. There's another quote that we've hidden in the interest of time about how labor was weak. For the students in the room, we asked ChatGPT. So ChatGPT had, you know, a very involved answer, actually, but they weren't mutually exclusive. It was the historical evolution was about individualism and a market-driven approach, and there's a little bit about price controls and employer and bargaining power here. And then the second one, again, not mutually exclusive, resistance to government intervention. So we just have a very strong tradition of this rugged individualism, which really means that this is what explains our divergent path. So what we want to do is kind of deconstruct those I's in the title. So we want to actually explore whether and to what extent an interest group, and here we'll talk about the AMA, the American Medical Association, though they had help from other interest groups, as we'll see in a moment, contracting with the very first political public relations firm known as Whitaker and Baxter, defeated a key component of social insurance. So social insurance against the four horsemen of the apocalypse. We're talking unemployment, we're talking disability, we're talking old age, and of course, medical or health insurance. That's the fourth component. So we got different versions of some of them, but not health. And the second I is the campaign focused on indirect lobbying. So you might be familiar with direct lobbying, quid pro quos or you know, payments for things like that. But indirect lobbying is actually trying to trying to change policy by changing the way people think, people on the ground, ordinary Americans. And the third I is actually ideology. So in fact, this is not really, if you look, and we'll show you some of the ads, it's not really at all about insurance. Like there's no information on the product. There's no discussion of what's covered or what's not covered. This is all framed in, obviously the backdrop of the Cold War. This is about freedom and equating really price freedom for doctors with the freedom to choose whatever plan you want. And so again, public insurance was described as compulsory, described as socialist, and there was also a push to enroll individuals in private or so-called voluntary health insurance. And it had just not only a short-term, but also this long-term goal. So this is Whitaker and Baxter, and they are the progenitors of much of this project because they are a firm. They had a firm, Campaigns.Inc., whose archives we were able to access. And this is one of their quotes. So the immediate objective is the defeat of the compulsory health insurance program in Congress. So when I say compulsory, you could read national health insurance. And if I slip into compulsory, just know that Yusra and I have been poring over these documents for about 8 months, so we were indoctrinated. And there is great urgency to that phase of the problem, but the long-term objective is to put a permanent stop to the agitation. And for the economists in the room, you could read demand for compulsory health insurance. And the most vital step in achieving that objective will be an all-out campaign to enroll the American people in voluntary, you can read private, health insurance systems. So the campaign's clear goals were to enroll people in private health insurance. So our approach here is to compile a variety of historical sources, many of which to our knowledge are novel to the literature simply because the archives were to the death of Whitaker and Baxter, and then their son actually bequeathed all of their invoices, receipts, and they kept so many of them to the state of California. So they're actually publicly available now. And then you can combine that with, new tools with OCR and machine learning, and that really unlocks a lot of this quantitative component that I think was really missing. And it definitely would have been missed if you just went to the AMA archives, which we did, in which you have to be a member to do. And I've been a member for 20 years. And there's no mention of Whitaker and Baxter. At all. So having a firm that's now defunct, have its outlook sphere was very helpful. So we're going to construct an exposure variable for national education campaign. And then we're going to look at the effects it had on public opinion, private health insurance enrollment, and then we'll also look at how it affected campaign contributions by doctors themselves to the 1952 Eisenhower-Nixon ticket, because by that time, Republicans had actually adopted as part of their platform that they were for private health insurance and against national health insurance. So that's what we do. So I'm going to skip over the findings. Again, this is just an economist thing. Too impatient, need the answers right now. So I'll tell you about those findings as we go along. We're obviously greatly indebted to Paul Starr. Obviously, we're indebted a bit. Absolutely to Jill Lepore, but we're also indebted to many economists who've looked at, the role of media and advertising and persuasion and all these things that actually, we didn't really think about when we thought about health economics per se. Where do we think we're contributing? Oftentimes the apparatus of advertising is brought to consumer products. We're thinking about it in terms of policy, advertising and trying to persuade people about policy, not a product. Oftentimes it's about direct lobbying, the influence of corporations on legislators. We're talking about how that money can be poured into, shaping public opinion. Maybe nothing, mind-bending today. A lot of work in the economics of culture is sort of where does this rugged individualism come from? Does it come from frontier exposure? Does it come from the places where people in the United States have settled? We're thinking about actually constructing individualism and leveraging it as a kind of weaponizing it in a way to kind of use it to convince people about the merits of a given policy. Consequences of licensing, that's a robust topic in neoclassical economics. Reduces supply, maybe raises quality, but what does licensing do for, professionalization and consolidation of authority and power? And lastly, a lot of discussion, I'm sure you're probably, maybe silently smirking to how many Economists have told doctors they're not Bayesian. That's kind of a favorite pastime of economists. But we're talking about not the behavior of individual physicians, but actually how do physicians act as a collective to kind of preserve their clinical and financial autonomy. So this is the roadmap for the discussion, and I won't necessarily go through the conceptual framework. So I'll probably skip over that. Any questions before we go into the history? Okay, all right. Again, very different from economic in a pleasant way, So historical background, there's just three things that we wanted to bring up. And again, oftentimes we're to audiences that have less familiarity. The first one is, we'll talk a little bit about, health insurance in the United States. Then we'll talk about the Paul Star, the rise of the medical profession. We're just going to add some data to that, descriptive data, and then we'll talk about Whitaker and Baxter and the rise of political PR. So pre-World War II, there's actually very little health insurance as we know it. There was, in fact, life insurance, Aetna and MetLife. It's kind of a common theme. I think that, no one really wanted a pauper burial. That was something you always wanted to have some insurance against. And so that, in fact, including life insurance in sort of Teddy Roosevelt's and very initial inclinations towards health insurance might have killed that, including sort of coverage for funerals and whatnot. The Great Depression obviously led to a huge decline in charitable giving to hospitals, who, the hospices, that those that administer to the poor, the nonprofits that were not state financed. And that actually began the experimentation, which what were called prepaid community schemes, i.e. Blue Cross. Now, FDR's New Deal famously left out insurance. So going back to those four horsemen, it did cover old age and unemployment at the state level, but definitely there was discussion at the time of the Social Security Act about including health insurance. There's, obviously a long literature about personal ties, concerns about the burgeoning medical lobby that could go against him. He really wanted to get old age intact. But during his fourth run for office, he actually embraced medicine. World War II was winding down. He actually embraced the right to medical care as part of his new second Bill of Rights or Economic Bill of Rights, but he suddenly passed away. And then this newcomer, Harry Truman, who was somewhat unknown, ascended into the presidency and actually turned out to be a very vocal supporter of national health insurance, much to everyone's surprise. But he was dealing with a Republican Congress, and all of that changed in 1948. So our study will be 1946 to 1954, and 1948 to 1950 is really sort of like the moment, AMA's Armageddon, if you will. This is probably pretty familiar. The professionalization of medicine, the growth of AMA membership, maybe less so through the Flexner report, basically said that the only medical school worth anything was Johns Hopkins, and everybody else shut down. No, half of medical schools shut down. Harvard obviously did not, but half of them did. The supply shrunk a bit, but more importantly, the inflow, the standards were raised dramatically. State medical licensing boards emerged and really became important for, you could be now liable if you were practicing without a license in a way that was just not true prior to that. The AMA then emerged in this vertical structure as sort of the coordinating body for all of these state agencies. And then, of course, due to public investment in both World War I and especially World War II, all of a sudden medicine had all of these new tools, the mass production of penicillin, new surgical techniques, and the returns to being a doctor increased, right? They had all these new tools, specialization increased, and that had pretty big ramifications for kind of the face of medicine. So, which maybe we'll go here first. Okay, so this is data we have put together. So the share of AMA members, this is, when I saw this, I was flabbergasted, but it's true. From 1920 to 1950, the share of doctors who were members of the AMA grew from 60% to almost 73%, which is really high. I think today I don't know if people want to show hands, like very few. I'm one. I think I was part of AMSA, the student organization. So I graduated, but not, I think it's 15 or 20% today. So it's very powerful at that time. And then you can see the share of specialists. That's the green line, left-hand side axis. It's going from 10% to a third over the same period, from the 20s to the 50s. So increase in the AMA, increase in the share of specialists. We can also look at, specialists definitely dominated the AMA in terms of proportion. So these are us trying to make sense of what they had as categories back in the day. But there's generalists, and then there's all of these different, internal medicine was considered a specialty at the time. And about 92% of specialists are members of the AMA in 1950, whereas only 56% of generalists were. We can look at the income growth of physicians. So massive increase from 1940 to 1945. This is, again, I think the returns to technological advancement and specialization. And you can just compare this. We've checked these numbers a bunch of times, we'll check them again, but certainly we're not seeing that same trajectory in the median household. So doctors are kind of increasing their specialization, increasing their membership in this organization, and they're increasing their wealth. Now, we talk about primary care not getting as much as specialists today. That was also true in 1950. So here specialists are earning, almost twice as much as a generalist, $15,000 on average versus $8,800, and much, much more than the average American family at $3,300 in 1950. And then the last point, because we were interested in this too, is just what's happening to the leadership of the AMA. And it's changing over time too. So these are moving averages, but you can see that the share of specialists the share of AMA presidents who are specialists is basically unity. By the early 1940s, the organization is kind of dominated by the specialists, which kind of explains their shifting views on insurance, which I failed to mention, but it's this last bullet. So the AMA was not always against national health insurance. In fact, if you think about it from the objective function of a generalist, they're subject to the same income shocks that their patients would be. And so for them, a steady stream of income might actually have been kind of a nice feature. But once it becomes power becomes concentrated in specialists, their preferences are much more about keeping on to that autonomy, financial autonomy, professional autonomy. And then the AMA really codifies in their House of Delegates that not only do they want to oppose national health insurance, but they're going to start their own medical plans, known as Blue Shield, and then they get together with Whitaker and Baxter. So Whitaker and Baxter, that's the last component to talk through. They came out of California. California, for those that have lived out there, about the recalls and the propositions and all of that. So in 1911, California amended its constitution, allowing for direct democracy, allowing for the people to speak themselves. And so Whitaker and Baxter, Whitaker being a former editor of the Sacramento Bee with lots of ties to Hollywood and lots of ties to advertisers, and Baxter, a widow who was part of the Chamber of Commerce out in California, they got together and just formed this company, and they seized the opportunity. There were lots of progressive propositions that were being brought to the people in California during this time, 1920s, and then going into the 1930s and 40s. And they considered California both, quote, the testing and the burial ground of progressive politics. And they felt some amount of pride in being part of the funeral service for these progressive politics. One thing that I mentioned that FDR did not have health insurance as part of the old age security insurance in the 1930s. Well, that didn't stop the, quote, agitation for health insurance. It just evolved to the state level. And a very strong governor, Earl Warren, in California tried to introduce health insurance half dozen times or something like that. Whitaker and Baxter were hired by the California Medical Association, and they were kind of there at every step of the way, developing a lot of the same techniques that we see at the federal level in 1948. So this would be the mid-1940s. And one of the things they actually did, because of course they are public relations, was not only did they take credit for defeating Earl Warren, we don't have the data test, unfortunately, how much credit they should get for it, but they certainly advertised. So they created a journal, CMA Public Relation News, CMA for California Medical Association, and we can actually see them sending it out to all these different state and local medical societies, including the AMA. And then once you have 1948, Dewey beats Truman. It's the upset of the the upset of all upsets, where Truman actually defeats Dewey, and you have a Democratic Congress, and the AMA is hiring Whitaker and Baxter. So this is the National Education Campaign, the AMA National Education Campaign, Whitaker and Baxter directors, and that's some of the paraphernalia or the propaganda, if you will, that they created, posters, pamphlets, and whatnot. We'll get into all of that. Okay, so there were two key components of this campaign, which covered the period 1948 to 1950. I mean, every good campaign needs a field component, right? A ground team. So the physicians were actually the ground crew. They received over 50 million propaganda pieces of the form that I just showed you, pamphlets, posters, etc., shipped from Chicago headquarters to state and local medical associations. These pamphlets, when we first saw them, and I previewed this already, were really about, big American eagle on the front. They're really about America. The voluntary way is the American way. 50 questions you want answered on compulsory health insurance versus health, the American way. Compulsory health insurance or politically controlled medicine, a threat to health, a threat to freedom, a message from your doctor. If you value your liberty, if you value the health of your family, turn inside and read this documented indictment of socialized medicine. So really not very informative about the product they're pushing, but very, very negative on national health insurance and on and very kind of hitting those notes about America and freedom. This is just if you looked at the pamphlets they were distributing. So you do see the word. So here we've actually taken out health and medicine, and you can see America comes very front and center, but that's just the pamphlets. When I bring in the ads, which I'll tell you about in a minute, we have more data to look from. This is not dropping anything. Again, you see America is the most important word, voluntary, medical, and then number 4 is actually freedom. So freedom is the 4th most common word in these advertisements in a moment. But in any event, the doctors were given these pamphlets, especially the AMA members, and they were tasked with handing them out, talking to their patients about private health insurance, getting them enrolled in Blue Shield. They also did outreach to local civic organizations. So they would get resolutions passed. So this is from the Medical Society of the State of Pennsylvania, reaching out to individuals at various local civic organizations, trying to get them to pass these like template resolutions that then could be sent to local and state officials. But in any event, you were supposed to talk with your doctor, not just about, this particular pill. You were supposed to talk to your doctor about insurance. And that's where also the newspaper ads came in. So this ad buy came in, really hit strongly, fiercely in October 1950. This was contracted out to a third party. So Whitaker and Baxter, along with the AMA, designed this ad, but then they used a third party firm, an advertising firm, to place the ad. It's huge. It's something that, again, you don't necessarily think this screams insurance. It's got, again, a very large American eagle. Who runs America? The Congress, the president, or you and the man next door? So this really, it's 980 lines. It takes up a full page. It talks about all the other organizations that they've gotten to sign on against compulsory health insurance. The voluntary way is the American way. Again, for more information, ask your doctor about insurance or your insurance plan. So those are the two options. Now, what kind of happens in the, in the cycle of research is inevitably I'm wrong. So one of those times that I'm wrong was when we were talking with Vanessa and we were saying, Vanessa is a research assistant, find this tagline, find this ad, because we wanted to figure out which newspapers were putting this ad. The voluntary way is the American way. Okay, Dr. Alshon, I got it. And then she was finding 3 or 4 ads per newspaper. Like, Vanessa, we know the history. They only took out 1 ad per newspaper. It was a huge ad. Dr. Alshon, I've looked at my code. I've checked it twice. I said, okay, show me the ads. And these were the ads. These were tie-in ads. And they were other industries helping out the doctors. So this is why it's actually interest groups. It's not just the AMA. So here's Walgreens. You might think that that's kind of, similar, but Free America has, so it's very ironic because of course penicillin mass production was a public investment, but setting that cantaloupe aside, like Free America, this is like the progress is more than statistic, it's people, the people we don't want to tamper with. Free America has no place for socialized medicine. The voluntary way is the American way. So she found the tagline, right? What about, this is for clothing. Rugged, non-ragged, to the doctors who are fighting for freedom, our salute. Their crusade for liberty is all of America's crusade. The voluntary way is the American way. And of course, if you were looking for farming equipment in America, the customer gives the orders. So you can think about the incentives, but again, they're smarting from price controls during World War II. The doctors are making this argument, first us, then you. And so the doctors are able to dramatically, by over 100 billion in current dollars, increase the ad spend by getting these other trade organizations to support them. And it's almost zero marginal cost ad anyway. Now all they have to do is like surreptitiously put in, this other component. Now we would be worried. So let me show you the industries. Any guesses? So, and by the way, we did actually, for all we talk about machine learning, a lot of Harvard undergraduates, we'll thank them. They actually went in and started looking, because then we were like, the code, it could be anything. We don't even know. Yeah, so they're finding these ads for us. So it's over 40% of the ads are actually from farms, insurance, retail. These are the MetLifes and whatnot. But you can see you're getting manufacturing, food, other things, all sorts of support coming in for the doctors. And we were worried because we were thinking, oh goodness, maybe we're going to get our exposure variable wrong. But in fact, almost all of the tie-in are in places where we see that running the main ad has all of these sort of linkages, kind of reinforcing, again, pretty subconsciously in some sense, the messaging. So obviously there were other factors contributing to the rise of private health insurance. Unionization, so again, with price controls, but actually if you look at the time course, and one of the reasons we stopped in 1954 is because Melissa Thomason, another economic historian, has looked at this. And 1954 was really when it was codified that, these would be tax-free employer contributions. And that's really when unions start pushing for this to become some part of their bargaining process. Before that, it's unclear what unions can bargain for in 1948. Some clarifications on that, but not really. So, and really at the time period we're talking about, unions were trying to back national health insurance. So they kind of went to this second best solution of bargaining for this after it was just clear that there was no national health plan. There's improved technological innovation. So we're going to try and take care of that with sort of secular fixed effects, enabling legislation. Most of these plans, obviously today, Blue Cross Blue Shield Massachusetts, Blue Cross and Blue Shield eventually merge, and they operate on the state level because there's enabling legislation that allows them to operate as nonprofits on the state level. So we'll look at things at the state level. We'll have state fixed effects in a lot of what we do. We'll include income, we'll include controls for levels of unionization. You know, I think again, in the spirit of Dr. Farmer and everything, thinking about equity, I mean, from the get-go, these plans discriminated against literally newborns. They were only for people, I mean, here, I'll just show you this is a chart from the AMA of factual data on medical economics. So this far precedes Canero. This is 1930s, 1940s. And so here you have on the y-axis income, and on the x-axis you have various categories of, you know, medical ailments. So the indigent, so the ailments are minor, major illness, chronic illness, and then institutional care and prevention. And so now you kind of see the medical school of public health, you see that divide right here. Prevention is a whole separate thing whose services can be provided by proper coordination of existing agencies. It's already sort of set aside. The indigent are a community responsibility. I think, so it's really, and then the top row, you can think about that as concierge medicine, right? That's free for service. And really it's just these few people that have some money, but maybe not enough to get into these insurance programs for acute and major, for major and minor illnesses. For chronic illnesses, I think that's funny. It's more of an economic problem.
I'm sorry, can you just say again where this
is coming from the AMA, from the Committee on Medical Services that has a Bureau of Medical Economics. Yeah. And again, this is well before, you know, the AER that kind of, I thought established health economics, but clearly they were doing it before. I'm going to skip over this. I'm happy to come back to it during the Q&A. It's just a way in which we kind of can formalize and nest everything that the AMA is doing in a sort of very straightforward model of median voter. Okay, so the data, how am I doing on time? Am I 3:10, is that right? Well, the data are really neat, thanks to, again, to Whitaker and Baxter. So, but I'll try and speed it up. So this is like the receipts, like they save their receipts. So this is the advertising company that they contracted with. So you can see that they're charging the AMA on LaSalle Street. They're taking out that 980 line ad. We know when it's being run. We know where. We know what publication. We know the circulation. So it's really detailed information that we're able to digitize. And there's just a lot of it. We also know where the pamphlets are being sent at the state level. And we can marry that with the Gallup poll, which various waves of which ask, you know, they're not going to be perfect, but they're all asking about the plans for national health insurance. But I'm going to come back to that because clearly these are not going to all be the same and they differ in an important way before versus after the campaign. Where do we get the insurance data from? This is also from that same Council on Medical Service. And again, it's incredibly detailed. And thanks to the people at Countway actually for helping us get these. So they have the name of the plan, the area covered, what type it is. This is what we're using as our major outcome, whether or not they have an association with Blue Cross, et cetera. So those are how we get those numbers. And so on and so forth. The other thing we can get is we can get more information from a newspaper archive, Ayers and Sons. Oops, sorry. Let's see. Nope, last one, sorry, my radio buttons. Anyway, Ayers and Sons has a lot of very rich data on, oh, here it is. Ayers and Sons have a lot of rich data for the students. So you can see the town, the population, you know, whether it's partisan or not, which is very neat. We actually have balance on that variable, which we were worried about. And basically this was an auditor of the circulation. So if you're an advertiser, you want to know if their numbers really are what they say they are. So that's the genesis of these data. Last one I'll show you, which is just the American Medical Directory. So now we have the master file. So, Scott, you and I are probably somewhere in the master file that the AMA has, but before they used to publish it. So one of my advisors, Claudia Golden, said sometimes the data historical are better. And they would cram so much here, at least they're available to us. So like the fact that this name of the doctor is capitalized means that they're an AMA member. That B apostrophe 14th is their year of birth, the place where they got their licenses, where they live, and whether they have an office in the same area. So this is all information that we can extract for the purposes of the analysis. And we've done some data quality checks, and these are other data. So yeah, it's a bit of data. So the empirical approach. So obviously we have to develop a campaign exposure variable. Here we're just going to add the two components. There's an MD component, there's an advertising component. We're going to take the per capita pamphlets and the per capita advertising circulation, which includes the tie-in ads as well as the main ads. And we're going to weight them by how they were being pushed in through society. So for the MD component, for the pamphlets, those were being distributed by AMA members. So that's multiplied by the share AMA. And then for the advertising, you had to have a certain amount of literacy to read those ads. So we're kind of putting a distributional weight of the share that have a high school education in the area. And so play around with this quite a bit, but it's not terribly sensitive to that specification. And we thought an additive specification was the most straightforward. Now we're going to standardize everything. So you can think of it as just one standard deviation unit increase in campaign exposure. And then we're going to look at the various outcomes of interest. So the first one, which is not well identified because we don't have time variation, we just have a cross section of how many civic organizations passed a resolution in support of private health insurance. And we actually don't even have a real denominator. Setting this one up for a lot of, I was keeping your expectations low, at least for the first one. Why? Because we don't actually have a comprehensive dictionary of all of the civic organizations that existed. So we're going to do two different approaches. One is we're going to denominate it by the number of churches in a given area as kind of another, and we're all population. But you should think of this as more of a correlation. We're not trying to causality here. We're just looking at sort of a group expression of public opinion, whether or not the civic organization passed a resolution. Now here we feel a little bit more confident. Here we're doing, what is considered sort of a classic difference in differences. When you have multiple time periods, you can use an event study approach. Here, the thing to point out is we're going to be controlling for the main effect of campaign exposure. So that's not really where the act is. We're going to be really interested in those beta coefficients, which are going to tell us, after the campaign actually starts, do we start seeing an increase, or sorry, in this case, a decline in support for national health insurance, which is what we would expect to see. We shouldn't see really anything going on from the main effect itself. Now, in everything that we're going to do here, we're going to be able to include a few controls, mainly controls for Blue Cross, which is at the hospital level, if you recall, controls for state level unionization, controls for unionization. And then because these are individual level data from Gallup, we can also include at the individual level, whether you're a union member, your education and your employment status. I'll try and go quicker. They all start to look the same. This is another event study. Again, you can kind of come away with the same thing. We're going to be able to control for campaign exposure. This one you're going to see, this is kind of a technical thing, but because this is at the individual level, your education, we can separately identify that from the, anyway, that's probably too much in the weeds. But in any event, you'll be able to look at campaign exposure as a balancing variable before and after the campaign actually starts. And so the event study, if we're really picking up the campaign shouldn't do anything before it actually starts, if that makes sense. Okay, and then we'll do the same thing for House elections. We'll look at how this affected the vote share for the Republican Party. And then we'll look at these data in Whitaker and Baxter actually has information on they started a PAC. You should think of it that way in the lead up to the Eisenhower-Nixon election. And so Whitaker and Baxter became directors of that PAC, and they have all of the receipts from doctors who donated, and we can individually link them to the directory. And see if they were an AMA member and see whether they donated and look at their exposure to the campaign. Okay, so this is just, obviously we're using observational data. How are we drawing causal inference? You have to kind of believe, and you can see, you can actually see here that, oops, I went too fast, that we actually have kind of balance on this variable, this campaign exposure variable. So this is almost like a balance table in a randomized trial with a pieced value across all of these things. We don't, in the pre-period, we don't have differences in the pre-period between places that were more or less exposed to the campaign, which is a good thing. But that's actually not what we're doing. And then this is just a map, so you can kind of see where the exposure was greater versus smaller at the state level. But I think what you'll definitely want to remember is that most of what we're doing is not cross-sectional at all. It's leveraging the time variation and the fact that you shouldn't see anything from the campaign prior to the campaign actually starting. Okay, so what we're going to see here is at the group level, so a 1 standard deviation increase in campaign exposure, this is the association, not causal, leads to about 0.3 more resolutions being passed per 100 churches at the state level. So if you're more exposed to the campaign, you're getting more resolutions being passed. This is denominated by churches. This is denominated by total population. We don't have any time variation here, so we're just kind of calling this more suggestive association. Let me just jump to the event study, because this is kind of where we can see prior to the campaign, not a lot of activity. In fact, if anything, perhaps going up in value. Support for national health insurance, that's what we're looking at here, Gallup data. And then when the campaign hits, it's a bit noisy, but we see this drop in support for national health insurance. That's the event study version of it. You can look at it as a table. What's really interesting here is that the pre-campaign support for national health insurance was incredibly high. 69% of people polled supported national health insurance. And when you add a 1 standard deviation increase in campaign exposure, you see that drops by 6 percentage points on average per wave. Now, you'll notice here, this line here shows you that the campaign exposure is doing nothing before the campaign. That's sort of what we mean by it's balanced. This second row here shows you that before the campaign occurs, there's actually nothing happening. It's all the action is coming in that post period. So this is how we can compare it to the pre-trend, which is, if anything, again, increasing support heading into the 1948 election. The other thing, the most important thing, obviously, is private health insurance. So here we're looking at the share of people by state enrolled in private health insurance. Again, you see the campaign, you can look at these two data points here, is kind of comparing high versus low campaign exposure in the pre-period. And we're getting nothing there. We're seeing that that's a tight 0. But once the campaign actually turns on, you see that having higher versus lower exposure to the campaign increases the share of individuals in your state that are enrolled in private health insurance. And we can then use the table to kind of back out exactly how big that was on average. Again, the campaign exposure in the pre-period does nothing. we have a 2.3 percentage point increase, that's the top row, per year on average, in the share enrolled in private health insurance. And before this campaign started, only about 3% of people in the United States were enrolled in private Blue Shield type programs. So we're accounting for about 75% of the overall increase over this time with the campaign. I wanted to say one more thing about the Gallup data itself, which, if you just forgive me just for a moment while I go back here to the data, simply because one thing that we are interested in is questions about questions. So you'll notice that the Gallup data kind of stopped a bit earlier than, like, we couldn't go out to 1954. And the reason why, and I mentioned this, I alluded to this, and then I'll quickly end, is here you actually see the way the question was asked in Gallup. They didn't use the word compulsory at all to describe health insurance. They talked about it as national health insurance or state-sponsored health insurance. But the purple dots are actually referring to national health insurance as compulsory health insurance. They've asked the way the question was asked altogether. And then the green is, it totally goes off the agenda. So now they're not even asking the question anymore. And that's kind of when you know you've won, when you're not being anymore in some sense. So just look, so that's why we don't really interpret the year fixed effects for, as anything for the Gallup. You can in fact interpret the year fixed effects for the insurance enrollment because it doesn't change. So this super well identified. We're trying to come up for an instrument, but in any event, we're interested here in, first of all, we've digitized 160,000 physicians, a little over 166,000 physicians from that American Medical Directory I mentioned. Here we can see, we can link them to the lobbying data in the archives of Whitaker and Baxter. We can see whether or not they donated it and whether they were a member of the AMA. So if you were an AMA member, you were much more likely to donate than if you were not, compared to the mean, which was just a small 0.2%. And if you were an AMA member that was also exposed more versus less to the campaign, you're even more likely to donate. It's about 1/7 or 14% as large. And again, the campaign exposure itself is doing nothing. So it's really only when interacted with the AMA. And then the last part is just, did this kind of pay off in the ballot? It did, at least in the short run. We see an increase in the vote share for the Republican Party. Again, this October was when the ad was run, so 1950 would have been the midterms, and then 1952 is when Eisenhower and Nixon are on the ticket. So the very last thing to show, and then be thrilled to talk about this a little bit more, is just what did this do to the overall narrative? So here, this is just suggestive. There's no causal inference, no event studies, nothing like that. It's just literally looking at the congressional record, which is already digitized. So all of the words that are said on the House and Senate floor, and looking out of the proportion of times that they say, if they're talking about health insurance, are they using the word national or compulsory, right? So before the campaign, they're using these things, in about the same frequency. And after the campaign, you see again, this word compulsory really starts to take off. National kind of takes a back seat. And we didn't go out much farther because it kind of goes off the agenda. So obligatory checks, we don't have a randomized trial. We did not helicopter drop pamphlets in some areas and ads in another. So we have to rely on these event study approaches. We have to show a lot of different things that people, in the biz are interested in. But I think in general, a lot of what we have to say, you can just see in the descriptive data. You can see how much they spent. Actually, I didn't tell you that. Do you remember offhand?
them themselves on the ads was like 20 million.
Million in
and
today's
then
terms.
The tie-ins were like 10 times that.
Yeah, 200 million, yeah. And actually, you said, could you say something about the public campaign? Like what was the countervailing force?
Oh, yeah. They were in a committee to try to convince, like within Roosevelt's administration, and I think their budget, it was like 100, it was like way smaller.
It wasn't $200 million.
It's like-
Yeah.
It's like counter detailing.
Yes.
And even labor quite a bit, if you can imagine. Okay, so we have we've found that a campaign organized by a political PR firm, Whitaker and Baxter, and financed by an interest group, the AMA, but again with lots of support from other trade associations, used ideology to sell private health insurance, enjoyed a lot of this other advertising from other firms. It caused a shift in public opinion away from national health insurance. It caused an increase in private health insurance enrollment. And you know, we can't say what the counterfactual was if, you know, it didn't occur. We have these differences between places where there was more versus less campaign exposure, and we think this is mostly due to pre-existing networks in terms of just how many AMA members there were in a particular location, and obviously proximity to Chicago and other kind of details in terms of the newspaper circulation. But we're living off of you know, before the campaign exposure variable doesn't seem to explain much. And so our other project right now is trying to understand why in a very different English-speaking country, well, in a very similar English-speaking country, it went the exact opposite way towards a beverage style model, and with the NHS in the UK around the same time, and also had a lot of pushback from the BMA, but was somehow able to surmount that. So that's sort of an active project that we're interested in. But thank you so much for your attention.
So thank you, that was fascinating. For all of us raised on All-Star, that was like a level of granularity and a different approach that I had a lot of questions, but I want to open up to discussion. Jean and then Vikram.
Awesome, thanks so much for that. Very gripping. I wanted to jump on the NHS thing, because to me, that's the comparison. You know, look at all these other countries that have the nationalized system. What's the major difference? What is a major difference with our country? They don't have 14% of the population that was previously enslaved, right? They don't have an underclass like we do. I think there was an article in 1619 New York Times that looked at this and said it's race. The reason we don't have a nationalized system is because of race. And so I don't see how you would be able to use an economic, a model approach to say the theory is that maintenance of white supremacy is the driving force, and it's papered over by, you know, doctors, class interests, and these kind of things. The same thing if you looked at right now, why was Trump elected? You would see the same MAGA, like American flags and things, you know, reducing government overreach, you know, dropping taxes. And get at what I think is the main driver is maintenance of white supremacy. So what would be your response to that 1619 approach, that it's actually something you can't capture like quantum, you know, digitizing stuff, that it would probably need a more qualitative historical approach to and does that confound any causal argument you might make? I mean, yes, the Baxter might have contributed to it, but they're just either on the line from, you know, the white supremacy interests, or it would have happened anyway without Baxter, because that's what a horrifically unequal society ends up doing. So yeah, I guess what would you say to what would be your response to the
Yeah, no,
1619
it's
assessment?
I mean, all roads lead to the original sin, but I think, you know, on an empirical level, we have state fixed effects, we can control for share of Black, and I think there was two competing narratives. I mean, 69%, and those were mostly white Gallup respondents, supported national health insurance before they started to oppose it. And the model kind of says there's two things. One is, you can move demand curves, whether or not you should, by providing disinformation or misinformation. You can do that. And what narrative you choose, you're going to base it on whatever is in the Cold War, it's going to be socialism. It's going to have an in-group, out-group flavor. Always, they had two things going at the same time. They had this massive power, advantage in terms of resources, so they could message much more frequently, convincingly, and they provided an outside option of private insurance to basically take away the incentive one would have, because medical care was becoming more valuable at the time, to take away like the public good aspect of it. And actually going back to Paul Starr, he talks about the two ideological narratives that were kind of combating at the time. One was, and still today, individualism, my choice, my freedom, my America, my opportunity. And the other is this kind of also desire that we have for equity. So I'm not, I think I can tell you empirically we can control for it, that it was high before it was low. And that, yes, I still think that they're going to, if you're a good advertiser, you're going to exploit the fact that there's racism and you're going to use that to say like the indigent, we don't need to care about them. And those people, by the way, are overwhelmingly people of color. And that's a narrative that can win, and you're gonna find that narrative. Yeah.
So I just a terrific talk, Marcella. Thank you so much. I want on the question of the NHS.
Yeah.
I'd suggest you watch the film The Spirit of 1945 by Ken Loach.
Okay. Great.
And I think in that you'll see two things. One, which explains why Britain went the other way. And there's a terrific recording of the speech made by Aneurin Bevan, who was the Minister of Health, where he basically literally stands in Parliament and he holds a symbolic bag of gold, and he describes the only way to build a national health service is by buying doctors with trinkets of gold. It's a very powerful speech, but I think he read the medical profession smarter than anyone else did back in the 1940s. But also, I think what that moment of 1945 it tells us is Britain redefined its relationship with its people by voting out Churchill, who won the war, and bringing in a Labour government, almost unthinkable. The man who won the war is defeated in a landslide, and a Labour government redefines the relationship between the government and a very class-ridden society and a very colonial society. So the question that I wanted to ask you was, how do you discount, how do you act? I know this is the difficult thing with all, the kinds of, this is how the tobacco industry got away for 50 years, right? By saying we don't have real proof. So the fossil fuel industry is getting away with what we're seeing right now. But still, there is one nagging issue in my mind. How do you discount the larger political climate that was happening then? And you allude to this, but the fact that the US around that time was trying to redefine itself as a in contrast to the Soviet Union. And some of those words that you described is about a larger social change that was happening, that was affecting every institution, including the medical profession, the local communities. How do you
cause the AMA to want to do the campaign in the first place, for example?
Yeah, and by the way, I'm convinced the AMA was culpable.
I would find that more compelling if there wasn't so much financial gain for them as well. I think advertisers and political, they're going to use Willie Horton. There's no doubt that coming out of World War II, there was a very strong narrative to push back against communism and socialism. It's hard to believe that wasn't also gripping lots of Western Europe at the time. But in any event, I think the idea more sort of theoretically is that you can find a narrative that resonates And if it's a successful thing, freedom, the American way, these are still really powerful kind of narratives that can be manipulated and used. Concerns about spending, resources on the others who are not worthy, that in fact, that entire deserving versus not deserving poor, I think we inherited from our brethren in the UK. We inherited a lot of the poor laws. And so I think that in some extent, I mean, actually there was a war ad council during World War II that became the ad council and was definitely trying to put forward a narrative that we need to have price freedom. We need to have price freedom. And that was part of this kind of pushing back against price controls more generally. So that, I'm not sure how, it's hard to say, but my honest response is that I don't know. But if you did it in a different era, if you did it during 9/11, I think the narrative would have been terrorism. It would be find that thing that makes people fearful and tap into that fear, use that fear to get what you want. I think, yeah.
Oh, well, I have like two separate questions. Like one is like really simple because I just missed it,
Yes.
and the other is like less so. So, what was the AMA's actual internal argument for the benefits?
Yeah. So, and I think that's a great question because it's easy to sort of vilify, but what the AMA had been doing and what they wanted to keep doing was they had been doing first degree price discrimination. USRA can't pay, Matt, USRA I'm gonna treat for free, Matt, I'm gonna price gouge. And they had the opportunity to do that for themselves.
That's the reason they did it. They're telling themselves is the reason they did it.
Well, they're saying
what was their
we want to have autonomy over decision making. We don't want political people to tell us how to treat our patients. So treating the patients is also about how much you charge. So that happened at an individual level, doctor and patient, and then it got codified into the group level. And Blue Shield was run by doctors, and they were doing that's where we got RVUs, that they were doing the price setting. That's exactly the origin. Now, what the doctors couldn't see in the 1950s, they tried to kind of keep the nonprofit status alive and do this community-based rating. But as soon as there's a margin, and that's also another reason we can't go past 1954, the private companies come in, they find a way to do supreme skimming and experience-based rating and kind of pushed aside until they ultimately also adopt experience-based rating.
Okay, I have a sort of a
Does
follow-up
that
question. Yeah, sure.
explain it?
Yeah,
Okay.
helps. So one thing this makes me think is that the marketing company firm was underpaid. I mean, think of the value of this firm, like, right? Like, this is
We
a
have their salaries,
hugely
you should
valuable
look, yeah,
service, right? Like,
Yeah.
like it's worth.
And they go
so
to
much
Europe
to them.
afterwards for
Yeah.
vacation. They
But like, how does this
like.
compare to like other campaigns to move popular opinion? It's a big, changing popular opinion is a really big task.
Yeah,
And like, it's hard to, and
yeah, that would be
that
good.
would be
We should look at
amazing if they could say,
tobacco. We
hey,
should
we-
look at tobacco and things like that,
It's
that
like-
would really, yeah, that's a
Okay.
good thought.
okay.
I can just say tobacco was incredibly effective using the same techniques. And what I found is in 1954, there was an editorial in the New England Journal that said, now that we know smoking is really dangerous, what are we going to do? And then in 1962, there's an editorial in the New England Journal that says, we just don't really know. And the evidence had just become, overwhelming by then. So I actually have a question about this is, the story of the AMA is that they were powerful, they used their resources effectively to change what might have been a rise of some form of national health insurance. But today the AMA is
Yeah.
incredibly weak. wondering, reflecting on this, if they had insight and resources and instrumental techniques to turn the public towards their point of view. When do they fail? And it gets at sort of Starr's larger argument that the AMA feared the government, but it was really big industry.
Yeah.
So I'm wondering how you think in terms of this analysis.
I mean, I think about it, that's a great question, and thank you for the tobacco reference. We should definitely do more on that. I mean, I think of that as, you know, how do you get anything done? Sorry, it's not quite as nihilistic as Jean's question, just like, but I mean, you just have to have a bigger interest, like you need, you know, those cartoons where you have the little dinosaur gets eaten by the Tyrannosaurus Rex and then Meg 2 comes out of the ocean. This is maybe not a reference, but you know, you have to have somebody bigger coming, because we did get the VA, right? Well, that's a big interest group of white men who were coming back from the war. The AMA also opposed the VA, and they had a sympathetic, charismatic and sympathetic General Eisenhower. Elderly people had grown accustomed to getting insurance, again, probably, you know, and were able to get an amendment to Social Security Act and traditional Medicare. So, I mean, I think doctors still have, and the doctors of 1950 didn't necessarily look like the doctors of today. I still think doctors have a forceful narrative. Again, I'm thinking very much of Paul Farmer. Like what difference can one person make? They still have that legitimacy that comes with actually taking care of people. And I think perhaps, you know, again, this is a historical piece and veering into the normative here, but perhaps an alliance of physicians who are fed up, did not necessarily foresee this coming, and they weren't those physicians anyway, plus non-insurance industry that is footing this bill and making the United States less competitive than it otherwise would be, you know.
Yeah.
And the narrative, obviously we need to have some reconciliation and feel like, you know, the narrative of equity has to somehow ideologically, we do care for each other. That has to win out against me, myself, and I at some point, you know, so.
It's funny.
Is there
Okay.
any entity who involved in that campaign instead of, no, in addition to AMA in that at the time?
There were other, so like the American College of Surgeons, is that the type of thing? They were, but kind of to Professor Brand's point, like there were not as many of them, and the AMA really had hegemony over all of so it really was the, you know, the medical lobby.
Well, the Black Doctors Association, what was theirs? They
So
opposed it.
interestingly, so the NAACP was for national health insurance. The NMA, which was the National Medical Association, was also for it.
Yeah.
However, then the AMA started to inviting them to things. Like, your identity as a physician means more to us than our, you know, our feelings on race. So yeah, so that identity went out, and the NMA started to kind of begin to oppose national health insurance, to which the NAACP is like, you've sold out. Yes.
I thought it was a wonderful talk. I want to get back to what Victor, because there is a historical figure like Paul in this in England, and that's an hour in Bevan. And Bevan himself came out of great poverty. His father died because he had a lung disease from being a miner. He represented the working class in a powerful vision of what the future should be for them. And he had an enormous effect in English society. we didn't have an equivalent to a Naram Bevan. But that's not the question I want to ask. The real question I want to ask is, we come out of the war totally different than the Brits do. They're completely impoverished. We are the strongest country in the world by far. We create the UN system. We have this enormous power. How does that fit into the story here?
I think it fits in the sense that, there was a sense in which it fits into how the narrative was shaped. So that you're very poor, so keep every dime you have and don't give any to the government, which would have worked in terms of not supporting the financing of public health insurance. That wasn't the narrative. The narrative was, we're a strong nation and we've done wonderful things. Our American entrepreneurship has created penicillin, and putting that on the individual rather than on the public sector, like literally taking credit for things that weren't at all due to individual doctors' entrepreneurship. But that was the, this idea that of individualism and being anti-socialist, that was just a winning, a way to connect with people. But I do agree, and in the model, it's outside the model that we didn't show, but charisma is the factor that you don't necessarily need $200 million, right? And Truman was not a charismatic in that regard. FDR, what do the kids call it? Riz? Okay. He had it. Obama had it, but made marketplaces. But in any event, some people have it, right? And when they have it, I think that can shut down even the most convincing fear-mongering, that is available. We're not communist. So buy your own health insurance.
Yeah.
One question, you were talking about the comparative cases and looking at the UK as well. Another one that'd be interesting is South Africa, which again goes more in the US direction and then goes a bit further. So in the 1940, they had a major election in 1948. Progressive physicians had been really pushing South Africa towards adopting a national healthcare system in parallel to what the UK had done. But conservative elements, and I don't know who those were, rallied against that. And so the push for national healthcare became the polarizing issue in that election. Conservatives won and then implement the apartheid system. Yeah. So that was a case where healthcare drives a country to the right with then really dire consequences that reach far beyond healthcare. So that'd be an interesting one as well. And the world of literature is probably mostly in English.
Thank you.
And it brings, if I can just hold on for a second. Yeah. And building off of Ficker's earlier comment, this relationship between the AMA shaping American politics and politics shaping the AMA, and also George Allen, these sort of counterfactual stories, when times the AMA didn't win, was that 1961 Operation Coffee Cup, and Ronald Reagan opposed to socialized medicine, which was an enormous campaign. I don't know if it was the same folks doing it, but
Whitaker and Baxter, I think they had moved on, but yes, they were the one first of many.
Which was, the kind of verbiage in that particular campaign was so, socialized medicine is the starting point to socialism taking over the entire United States, and it's verbiage that we still hear today. Yet the AMA lost that campaign, and how you use that to disentangle what shapes what.
Yeah.
Have you looked at the impact of that particular campaign on access?
We're looking on. So we don't have. We're really excited to have these particular private firms' archives, or other we wouldn't even know that this campaign really existed for the most part, much less sort of the details that we were able to obtain. And our methods kind of, we wouldn't want to go out very far in time because then you have this kind of same with Tuskegee. I kind of enjoy doing history for history, and there's kind of a push to look at long-term effects and things. I think what things we want to do on our plate is to look at echoes of the narrative in the editorial pages, like places where they took out a lot of advertising. Do we see the editors kind of skewing in the next election? Maybe we could look at the first introduction of traditional Medicare. But I think without knowing too much, I think about that particular campaign, successful progressive politics seem to come from perhaps that charismatic X factor, and I think other more powerful interest groups. So.
This is probably a really naive question, but I just don't understand. You mentioned the non-insurance industry and how it is obviously suffering because of the lack of national health insurance. I would have expected that they would have enough power to move the needle on national health insurance, but they don't seem to be having much of an impact. And they don't even seem to be trying to have an impact. Why not?
That's a great question. And I do not know the answer to that. I don't know if there's, I'm not in the room where it happens. So my interest in, all things corporate is minus infinity. So I don't know what happens in the C-suite. But I would think that if there is going to be an entity that is more powerful than, than United, than Aetna, than Cigna, I think Cigna's merging with Aetna or something like that. I think it's going to have to be just, someone that has a lot of money and looks at it and says, it's eating into our competitiveness. Like all of that, that's such a misallocation of talent, of MBAs. No offense if all of your children are.
Your presentation today was just great, and now I'm very curious about what would be your next step.
Well, we'd like to write this in a paper. So we have a draft, and we kind of go on like a little circuit, get feedback, tobacco, 7, we'll do that, and we're so grateful for the comments. And then then we have other projects. I'm really grateful to be working with UCR. We have a professor at Ellis, a UCL that we're working with on the UK side. So any thoughts on that are welcome. And then we're doing some stuff on jail health, which I can talk about later on. Maybe I don't keep everyone here boring you with jail health.
One question I had about
Yes.
Measuring the impact on physicians at the time,
Yes.
right, in their own discourse. Have you looked at state medical journals?
So briefly, only to look at, and I think this would be great, Scott, for your next book, because I have noticed, honestly. So
I'm going here.
So the AMA, they did two $25 assessment fees on their membership to kind of fund parts of the campaign. But in addition, they did put on sort of like, in order for you to be part of the House of Delegates, you cannot be in arrears with these fees. And the number of delegates we have depends on how much people have donated to this. So very interesting and very aligned. They were kind of, the language was very consistent throughout in terms of just, this is the American way of freedom, price freedom. It also strikes me as a very interesting thing. This would be more in the qualitative realm, David, would be, there was just a relationship between the AMA and the University of Chicago. They're so close together. And I've always wondered, like, how did economists become powerful? Like, they don't have the technology that doctors had. So and doctors actually wanted the narrative of choice too. So, so did pretty much anybody selling anything. Anybody selling anything wants you to have choice.
Peter Swenson claims that not only was the AMA based in Chicago, but the radicalization of doctors towards the right, like 1920, starts at the Chicago Medical Society, or not that that's the university. of
Oh,
Chicago.
that's, no, but
J-
I
J
mean,
Bears
they're
is
so
all- it's all
close.
right in that area.
They're so close, so, yeah, did we like rub off our legitimacy on, anyway. Another book.
Another book. We have digitized every state medical journal.
Oh, wow,
yeah,
that's great.
And it's full text searchable and if you're tracing those terms from, and I always claim, like, if you pull off anyone from 1950, you'll find these terms, but I don't know if it happens if you pull out 46 or, so definitely.
That would
talk
be
about-
neat,
yeah, yeah, yeah.
that would be neat. Okay, thank you so much.
That was-